Thank you. I'll also try to keep time. But just to mention how I landed in cardiovascular disease risk after pregnancy. Carrie knows the story. So my initial research was on HIV and maternal health. That was my strength. And then we were trying to apply for this grant that says you cannot cover HIV, you cannot cover maternal health. You have to think outside the box and see what else. And I think it was also excluding mental health, because we had a similar grant at the University of Nairobi. So here we were with Carrie trying to figure out what else can we look at. And then I decided, I have strength in maternal health. We can look around something about cardiovascular health in women, because that's an NCD. How do we link the two? And then we got ourselves reading around the cardiovascular risk after pregnancy and developed an idea and submitted it to NIH, and it was eventually funded. And because of that, I went much more deeper to understand the cardiovascular health of women after pregnancy. So I want us to review a bit of the global evidence on risk of cardiovascular disease after pregnancy, understand the association between postpartum metabolic syndrome and cardiovascular disease risk, and updates on CVD risk after pregnancy study that we have conducted in Kenya. So we all know that cardiovascular disease is the leading cause of death globally, and 3/4 of these deaths or more occur in low and middle income countries, Kenya included. When you look at the mortality in the US, it showed that there has been a decline to about 1/3 of what it was in the 1960s, but there has been a bit of stagnation around those who are 55 years, especially women. And part of the reasoning is that it could be due to pregnancy-related cardiovascular disease risk. The sparse data from low and middle income countries where the highest burden of this disease is. Now, this slide is from the WHO. I think it was released about a year ago, looking at the leading causes of death globally. And this emphasizes what we already know, that the leading cause of death is cardiovascular disease, including ischemic heart disease, stroke, and others as well. So we really need to concentrate on cardiovascular disease health. One of the things that has been shown increasingly is that adverse pregnancy outcomes increase cardiovascular disease risk. So adverse pregnancy outcomes, which increase cardiovascular disease risk, are many, and they include hypertensive disorders in pregnancy, especially the new onset hypertension in pregnancy as preeclampsia or gestational hypertension. Women who have diabetes for the first time in pregnancy or gestational diabetes, preterm delivery, fetal growth restriction, low birth weight or small for gestational age, and placenta abruptio. As a matter of fact, in 2021, American Heart Association and the NIH included the adverse pregnancy outcomes for the first time in the heart disease and stroke statistics because of the role it plays. So why is it that preeclampsia or gestational hypertension increases the risk of cardiovascular disease? There's two schools of thought. There are those who think that there's shared risks and also that pregnancy may be playing a critical role. So in the shared risk hypothesis is that this underlying risk that is modified by pregnancy. So pre-pregnancy, these women have insulin resistance, endothelial dysfunction, systemic inflammatory response, or susceptibility genes that put them at risk of cardiovascular disease. And pregnancy now comes in as a stressor that exposes them to have the manifestation of these symptoms. Then also pregnancy itself may accelerate the process, and this may worsen the already existing dyslipidemia, inflammation, angiogenic imbalance, or metabolic or vascular maladaptation that may occur. So if we know that there is risk, as we're reviewing this topic with Carrie, we said there are risks. What are the challenges that we have on addressing cardiovascular risk after hypertensive disorders in pregnancy or adverse pregnancy outcomes? So the idea is to reduce this risk by either targeting women at highest risk, because you have to identify those who are at the highest risk so that you can institute the interventions. You may use clinical pregnancy outcomes. So you say you had a preterm birth, you had a fetal growth restriction, maybe you're at higher risk. Targeted screening for those women who had adverse outcomes or these complications. Do we have the best interventions for them? Looking at literature, there is none that is actually recommended for these people. People are still trying so many things. How do you follow them up, for example? Because we know they're at risk, but when you look at what happens in our postnatal clinics, nobody cares. You know, you try to manage their blood pressures. Once it is controlled, that's it. You try to manage their blood sugars when they are controlled postpartum, that's it. But then for those of us who have been in the field for 10 or more years, some of these women come back later to see you, and then you realize now they have type 2 diabetes or they have chronic hypertension. So it's their follow-up that we should have for these women. And then if you follow them up, what is the best screening tools for their risk of cardiovascular disease? Do you use biochemical markers? Do you use clinical indicators like blood pressures? Do you use inflammatory markers, or do you use any imaging studies like echoes or things like that? So some of the associations, including the American College of OBGYN or the NICE guidelines, suggest some sort of follow-up. So they say you see them at 6 weeks, assess their cardiovascular risk factors, you check their blood pressures, BMI, okay? And then you look at long-term scoring system for their cardiovascular risk and lifestyle counseling. You can also look at them, you know, later at 8 to 12 weeks, still as the obstetrician, looking at the same parameters up to 6 months, for example, or up to 12 months, okay, and checking their lifestyle, their BMI, their blood pressures, and any other parameters that you may need to. What we see with these women is when you send them now to, you know, the primary care provider or the physicians, you lose them to follow up. The next time you see them is when they're pregnant again, sugar's not very well controlled, or their blood pressure is extremely high. So we thought that one of the things that we could evaluate is metabolic syndrome. So we look at the prevalence of metabolic syndrome in these women and follow them up over time and see whether this changes over time. And why did we target metabolic syndrome? Because looking at the literature, we found that those who have metabolic syndrome have a higher risk of cardiovascular disease, including ischemic heart disease, cardiovascular disease mortality, all-cause mortality, and type 2 diabetes mellitus. When we looked at the burden of metabolic syndrome, there were a few studies in Africa at that particular time that estimated the prevalence to be about 5 to 40%, depending on the setting where you are working. In Kenya, it was about 35%. In Ghana, it was about 36%. And in all these studies that we looked at, this is general population. On all these studies that we looked at, the women had a higher prevalence of metabolic syndrome compared to men. So we decided to use a criteria for measuring metabolic syndrome because there are different criteria for metabolic syndrome, which I won't go into, but the one that we concentrated in was that the harmonized criteria developed in 2009 that had no absolute criteria, but said if you had any of these abnormal parameters, the waist circumference, triglycerides, HDL, blood pressure, fasting plasma glucose, then any three of them would meet the criteria for metabolic syndrome. As you can see, some of them had an absolute criteria which you could not measure in clinical setting, like insulin resistance, for example, before you look at the other clinical parameters. So we found this to be a more agreeable approach. So we looked at metabolic syndrome after hypertensive disorders in pregnancy. Any studies that had been done, we looked at studies done in several countries, and we found that the prevalence of metabolic syndrome, or even the incidence, was 2 times or more higher in pregnant women or postpartum women who had hypertension compared to those who did not have. These were heterogeneous populations. Some of them were 6 months postpartum, others were 1 year or up to 3 years postpartum. But there were limited studies at that particular time in Kenya or sub-Saharan Africa, where the highest burden of the metabolic syndrome was estimated to be. So we designed a study that had 3 specific aims. One was to determine the prevalence of metabolic syndrome in women with versus those without hypertensive disorders in pregnancy, with or without gestational diabetes at 6 months, 12 months, 24 months, and 36 months post-delivery. Then we looked at the socio-demographic and clinical correlates between the 2 groups, those who had metabolic syndrome compared to those who do not have metabolic syndrome, and also compared the levels of inflammatory markers, the high sensitivity CRP, and other inflammatory markers between those who had and those without metabolic syndrome at 6, 12, 24, and 36 months. So I will not present the results for the second and the third objective because of time and because we are still doing some of the analysis. So it was a prospective cohort study. Our population were women followed until 6 to 36 months postpartum. Exposure was hypertension or gestational diabetes, and an exposed group were those who had normal blood pressures or sugars during pregnancy, and the outcome was metabolic syndrome over a timeline of 3 years. The challenge we had was, and it's something that we are addressing in our clinical setting now, is that not everybody is screened for gestational diabetes. So there may be a bit of misclassification because of that. So we included women who are 28 years old or older, who are HIV negative and were not planning to become pregnant for the next 3 years or so for follow-up, which was a big challenge in our setup because following up people I planned through this over 3 years is not easy. And then they had to reside in Nairobi or suburbs within 50 kilometers from Kenyatta National Hospital for ease of follow-up. So we excluded anybody that we thought had a pre-existing metabolic syndrome or its treatment, like hypertension, diabetes, or use of statins and insulin, or those who are unstable, and those who are not willing to be followed up for 3 years. This was a challenge because COVID came after that, and follow-up became very, very difficult. So our study procedures, we screened women at discharge when they were through with their postpartum care. We determined the exposure from medical records and interviews, and we enrolled them within 12 weeks postpartum at the study clinic through interview and physical examination, confirming their status, and then followed them up for 6 to 36 months postpartum, where we did interviews, physical examination, and blood draws for the test that I had mentioned earlier. So to our results for our first specific aim, looking at the prevalence of metabolic syndrome, comparing women with or without hypertensive disorders in pregnancy at 6 and 36 months post-delivery. So the slides, I hope it's clear, but basically we had 63 who are followed up, who had been exposed, versus 131 who were unexposed, who completed follow-up at that particular time. The challenges with the follow-up was because of the COVID-19 pandemic. So baseline characteristics between the two groups were similar, except for parity, which was higher in the hypertensive disorders in pregnancy, and gestational age was lower, again, the hypertensive disorders in pregnancy. And we think this was because we are a referral institution. So women who have had bad outcomes before because of their hypertension were likely to come to us. And then delivery, when women have hypertensive disorders in pregnancy, is usually at a lower gestational age. The other characteristics were infant birth weights, which were lower in the hypertensive group, of course, because of the preterm birth that they are more likely to have. High prevalence of stillbirths in this population. We are a referral institution, so they are referred very late. Exclusive breastfeeding, again, occurred in the hypertensive group because we are able to monitor that when they delivered preterm. Their pressures were definitely higher, and their BMI was definitely higher as well. So the risk of metabolic syndrome was about 35% versus 12% for the control group. So it was 3 times higher. And that is what we had proposed in our hypothesis. And when we looked at the components of metabolic syndrome, so overall the metabolic syndrome was 3 times higher. And then the blood pressures was the main component that was higher in this group as expected. Triglycerides were also higher. Fasting plasma glucose was also higher, but the HDL cholesterol and the waist circumference were not that different between the two groups. When we followed them up to 6 months postpartum, 36 months postpartum, we found that the prevalence was higher again in the hypertensive group compared to the normotensive group. But overall, as you can see, the prevalence of metabolic syndrome was slightly higher within the two groups. And this is probably consistent with what we found in the general population, where the prevalence of metabolic syndrome in women was about 40 or 45% in our setting. But again, what we found, it was slightly higher in the hypertensive group compared to the normotensive group. When we looked at the components, the blood pressure, and the fasting plasma glucose were the main differences between the two groups. And this may explain some underlying probably insulin resistance, which we may need to look at a little later so that we can conclusively come to address that difference. So in conclusion, our study has shown that hypertensive disorders in pregnancy is associated with threefold higher risk of postpartum metabolic syndrome as early as 6 months postpartum, and this increase remains nearly twofold greater at 36 months. And the main elevated components of metabolic syndrome at 6 months were triglycerides, blood pressure or elevated blood pressure, and fasting plasma glucose versus blood pressure and fasting plasma glucose at 36 months. And we need to look into this more to find out if there's a component of insulin resistance or increased inflammation that contributes to this. My acknowledgements are to my mentors from the University of Washington, including Carrie and Stephanie and Steve and James Kirkpatrick that helped us with some imaging aspects of our study, and those from the University of Nairobi and Kenyatta National Hospital, and our staff that have worked with us to ensure that we have this data, and of course the participants that, especially those that remained on follow-up for the 36 months, and also KNH Research Department that has been very supportive of our work. Thank you.
So thank you so much, Alfred. That's really exciting work. Does anyone have questions they'd like to ask Alfred based on this research? Let me go to notes.
Really nice work. Really enjoyed it. Thank you. I'm starting to look at cardiovascular disease after pregnancy, so I'll talk more afterwards, but I do have a couple of questions. First of all, did you exclude, I assume you excluded those with metabolic syndrome prior to pregnancy? And next question is, do you store blood on these people for future studies? Because we have a number of studies that we're thinking of doing, and we should talk more.
Thank you. Yeah, so we tried as much as we could. Unfortunately, we are not able to see these patients before pregnancy, so it was difficult for us to determine whether they had metabolic syndrome or not. But basically, what we did in our exclusion criteria is to exclude anybody who had pre-existing hypertension, diabetes, because we thought they could be having pre-pregnancy metabolic syndrome, or if they had malignancies, or if they were using other drugs like statins or insulin or oral hypoglycemics or antihypertensives, then they could be having metabolic syndrome as well. So that's what we used as a criteria. So there could be a bit of misclassification in some of those we may not have identified, but we tried from the clinical setting as much as possible to try and exclude them. Yeah. In terms of storage of blood samples, we have blood samples, but the problem is where to store them. Because we ship some, actually we shipped all the samples here for analysis, but frequently or once in a while we get emails telling us that you need to get, find a place to store your samples because our lab is full. Yeah, our labs, our lab space is full. Yeah. So we can discuss. Yeah. Yeah. Okay. So we can discuss over it, but we have all the samples from the study. So yeah. Yeah. Okay.
A space. Hold on. We're talking about storage of blood samples.
Yeah, no, we have space at South Lake Union, which is, I think, probably where Nana's space is as well. But I want Steve to be able to ask his question.
By the way, I just got back from Mombasa recently, and the space and the capacity for storage of samples is really incredible. And I was also really impressed with their policies of not sending stuff to the global north and keeping stuff there for local analysis, which I think is, better than storing them here. So it's just my own 2 cents. My question is that I spent a bunch of time in antenatal care clinics in Mozambique and in Cote d'Ivoire. So those are the countries I know best. And frankly, outside of Maputo and Abidjan, the capital cities, it's very common to either have no blood pressure cuff or cuffs that are not working very well, or people who don't know how to use them. And blood pressure is pretty frequently either not taken or inaccurate in rural clinics as well as in smaller cities. And the same is true with diabetes screening. Because the diabetes screening, I mean, doing a fasting blood glucose is, I suspect, is not something that's particularly easy. Even a urine glucose is not great. So my question is, to what extent, Kenya, I think, is a little different because you're better off than most countries in sub-Saharan Africa. But what's your feeling about the accessibility of actually screening for these two conditions, which you've very nicely sort of shown, have a big driving force for metabolic syndrome? What is your feeling about the accessibility within prenatal care throughout, say, sub-Saharan Africa or South Asia, to be able to monitor for these pretty, important and obvious things?
Okay. Thank you very much. I think that's an observation. That's a correct observation that you have made, that in most of the LMICs, and even in Kenya included, there are areas where accurate measurements of things like blood pressure, weight, even weight itself, or just sugar is not accurately done. For example, at the National Hospital, we are even struggling with universal screening for gestational diabetes. I think it's more to do with implementation, because people know what to do, but for some reason the lab is not very supportive, or the clinicians are not ordering for the tests. And we are trying now to do studies to understand where the problem actually is. So that is something that needs to be addressed. Now, in terms of what I've seen over time is that the quality of care is sort of improving now. I think previously everybody was using the mercury, the sphygmomanometer, mercury for measuring the blood pressures. And I think when it was not functioning well, people would not know. If people may not even know how to use the stethoscope, especially nurses or doctors working in the rural communities. But I think now, because of the electronic, blood pressure machines, I think it's a bit more accessible now. Now you even have patients who buy their own blood pressure machines and check their own blood pressures. So I think things are improving, but we can do better in terms of just ensuring that these services are available. There is a small study that we are conducting on high blood pressure in pregnancy, and some of the challenges we get, even from the sub-county hospitals, that the blood pressure machine is not working. So they're asking, if the study can buy for them blood pressure machines. So there are still perennial challenges, but I think it's much better than what it could have been maybe 10 or 15 years ago. It's something that needs to be continuously addressed and monitored. Yeah. Thank you. Yes.
Very brief comment.
Just a brief comment. I love that you showed the relative risk. It'd be also nice to see the absolute kind of values of how people were, like which factors people were qualifying for metabolic syndrome on, right? So, not just the comparison of hypertensive disorder of pregnancy versus, control. So you're seeing the relative risks there. But if you could actually show like, the absolute prevalence of each of these things. Okay. My suspicion is that most people are qualifying on blood pressure and waist circumference. And ultimately, lipids, I just don't think are a major driver of cardiovascular disease in Africa, but we can talk more about that later.
Yeah, so I had those in the other slides, but unfortunately, I was not able to include them because of the congestion and the time. Yeah, but we can share. Yeah, that because this work, the initial one at 6 months was published, so it's in it's out there with all the numbers. But then the second one has not yet been published. So once we are ready to publish, you'll have all the details. But I have all the numbers in case you need to get them after this. Thank you. One more question from this.
Oh, we've got 4 more minutes.
Not this slide, but one of the previous slides that you showed, how many people in each group had metabolic syndrome. I think it was like 50-something% after 36 months. Okay. Were you surprised by this number? I mean, it's quite high, even with the ones without hypertension, half of the women having metabolic syndrome. Could you help us put that in context?
Yes, so yeah, when I got this, because this is just work that I got, I think about a month ago, definitely I was a little surprised because the numbers were pretty high. So I had to look at, if there are any other confounders that we not address or not. What we may have not captured fully is contraception. So the role of contraception in this is something that we probably need to look at a little bit more, because we know some of the contraceptives may, result in increase in weight and may raise other parameters as well. And again, the duration of use of those contraceptives may also be critical. But the reason why it was not really that surprising is that some of the work that we looked at before, looking at the overall prevalence of metabolic syndrome, as you can see, it was higher. In Kenya, it was about 40%, just looking at adult population. And in Ghana, in women, it was about 54%. So that just tells you that in the general population, the metabolic syndrome may actually even be higher than what we'd expect in the immediate postpartum period. Yeah, but as you say, it caught me by surprise, and I had to look at it a few times. Yeah, thank you.